What's up, CardioNerds? This is Dan and Amit, and we can't thank you enough for tuning into CardioNerds. Your support as listeners since December of 2019 means the world to us.
We are honored to announce the birth of a new podcast, CardioNerds Cath Masters, designed to democratize interventional cardiology education. This is intended for an advanced audience with a strong technical foundation. At Cath Masters, we aim to deliver high-quality, evidence-based, and experience-driven procedural education across all segments of interventional cardiology. If this resonates with you, we invite you to check out Cath Masters on your favorite podcast app. As you have done with CardioNerds, please do rate and subscribe to the show to help others seeking interventional cardiology education also find Cath Masters.
The breadth and depth of CardioNerds education have been possible because of all our collaborators within the CardioNerds Academy, Healy Honor Roll and Fellowship programs, and several cardiovascular professional societies. We want to take a moment to thank them all for supporting our mission to democratize cardiovascular education. And of course, thank you for tuning in.
Worldwide, cardiovascular disease affects the lives of hundreds of millions. Dedicated cardio nerds everywhere are working hard to fight this global epidemic. These are their stories.
Hello, cardio nerds. Before we start this episode of the CardioNerds Pulmonary Embolism series, I want to give you a quick disclaimer. We recorded this discussion before the HyPytho trial results were released, so you'll hear us talk about HyPytho as an upcoming study. Since then, the data have been presented and published, and they meaningfully advanced the evidence for catheter-directed thrombolysis in intermediate-risk PE. HyPytho was a multinational randomized trial of 544 patients with acute intermediate-risk PE, all with RV dysfunction, elevated troponin, and additional markers of cardiorespiratory distress, but without overt shock. Patients were randomized to ultrasound-facilitated catheter-directed fibrinolysis with low-dose alteplase plus anticoagulation versus anticoagulation alone, using a standardized ECOS protocol. The primary endpoint was a 7-day composite of PE-related death, cardiorespiratory decompensation or collapse, or symptomatic recurrent PE, adjudicated by a blinded committee. The trial met this endpoint. Events occurred in 4% of patients in the catheter-directed fibrinolysis arm versus 10.3% in the anticoagulation alone arm, a relative risk of about 0.39. This benefit was driven mainly by fewer episodes of cardiorespiratory decompensation, while early mortality and recurrent PE were low and similar in both groups. Crucially, this reduction in early clinical deterioration did not come with a clear major bleeding penalty. Major bleeding at 7 days was 4.1% with catheter-directed fibrinolysis and 2.2% with anticoagulation alone, a non-significant difference, and there were no intracranial hemorrhages in either arm. So as you listen, keep in mind that our conversation reflects the pre-HyPytho uncertainty. HyPytho now provides randomized evidence that ultrasound-facilitated catheter-directed thrombolysis can reduce early clinical deterioration in carefully selected intermediate-risk PE patients without a clear increase in major bleeding, though it does not show a mortality benefit and relies on a composite endpoint that heavily weights cardiorespiratory decompensation. It moves catheter-directed thrombolysis closer to an evidence-based option for this population, while ongoing and future trials will continue to define exactly where it fits in practice. With that context, let's get into the episode.
Welcome back, CardioNerds. This is Dan Amateur, one of the CardioNerds co-founders, and I am so excited about this episode as part of our Pulmonary Embolism series. Today, we're looking forward to discussing the long-term management of patients with pulmonary embolism. And so without further ado, I'll kick it off by introducing our team. We have one of our CardioNerds PE Series co-chairs, Dr. Joe Mullinax, who is an interventional cardiology fellow at Emory with particular interest in pulmonary embolism management and complex PCI. Joe, take it away.
Hello, everyone. Hello again, Dan. Thanks for the introduction. Such a pleasure to be a part of this ongoing PE series and introduce our fit lead for this exciting episode. This morning, we have Dr. Saahil Jumkhawala joining us, who is a cardiology fellow at the University of Miami and a house faculty leader for the CardioNerds Academy. Welcome, Saahil.
Thanks so much, Joe, and thank you, Dan, as well. I'm so honored to be joining you all today. Today, we have the pleasure of learning from Dr. Soophia Naydenov. Dr. Naydenov is a professor of medicine in the Division of Pulmonary and Critical Care Medicine at WashU St. Louis and Barnes Jewish Hospital. She's also the pulmonary director of the PERT program at WashU. Dr. Naydenov, thank you so much for taking the time to join us and to share your expertise with us today.
Thank you so much, guys. It's really my pleasure. I'm really thrilled to be here and discuss the topic, which is very near and dear to my heart and a very important one for the pulmonary embolism patients.
Perfect. Thank you, Dr. Naydenov. We're going to start this off with a case, so we hope you will help us guide through the management of a patient we saw in our CardioNerds clinic. Patient's name is Miss Embolism. She's a 56-year-old accountant who was hospitalized with a segmental pulmonary embolism 4 months ago following a long-haul flight. She was treated with anticoagulation, discharged in stable condition, and told she'd likely make a full recovery. However, Emma's continued to struggle with shortness of breath, fatigue, and a strange tightness in her chest every time she's climbed stairs, a significant change from her functional status before her PE. Her clinical exam is normal, without signs of right heart failure. Dr. Naydenov, can you tell us more about post-PE syndrome and what the spectrum of this includes?
Of course, again, such an important point. And I think just the example from this patient who has completed around 4 months of anticoagulation therapy and apparently healthy at the baseline, I'm assuming, with some symptoms that are concerning. So let's kind of tease out the terminology a little bit so we are all on the same page. I would just advise a little bit of caution when we use the term syndrome, post-PE syndrome, because in my understanding, syndrome refers to something, which you're trying to lump together or as a one entity, where here we're really talking about a spectrum of disease, and that's important to tease out. And even if we use the terminology, that's all right, as far as that understanding part is there regarding the spectrum of the disease that we are talking about. So first and foremost is the patient we are discussing is the one, as I mentioned before, has completed 3 months of therapy on anticoagulation. So that's kind of the base. And then if they're still symptomatic afterwards, that's another second piece, which is very important. And symptoms can vary, as you all already know from your clinical practice, starting from just maybe some fatigue or dyspnea, or in this patient, like a little bit of chest tightness, and so on and so forth. So that's kind of the patient population you're referring to. What it is, if you discuss the post-PE, I'm with caution using the word syndrome, is that we're talking about sequelae of PE, like symptoms that exist now in a patient's life that they didn't have before. They didn't have before they had this incidental PE. It's like a storm hits you, and then what is the damage that is left? It's kind of like that. So they have recovered to some degree, or they have survived the initial event, but the sequelae is what we are talking about. And as we mentioned, and you asked, that it's a spectrum. And there's some clarity in one extreme of the spectrum as far as CTEPH is concerned, which we are familiar with in the scientific world, chronic thromboembolic pulmonary hypertension. The definition is clear, though it's a most deadly type, thankfully, it's rare, 2 to 4%. And on the other side of the spectrum is a milder disease where maybe some fatigue or dyspnea or inability or impairment that the patient perceives. So that's kind of the other extreme. And in between, another term used frequently is CTED, which we are learning a bit more every time, which is different from CTEPH, where CTEPH would be somebody with a residual clot, and pulmonary hypertension, which we can identify or see at rest. And then CTED is somebody with maybe residual defects seen on a VQ or a CT scan, but they don't have that pulmonary hypertension piece. So these two are a little bit clearer as far as definitions are concerned. However, when you talk about post-PE impairment, where these two definitions are not met, the patient still has symptoms, would be that other spectrum of illness. So this is the entire spectrum from some kind of a mild recovery phase, which may or may not develop in one direction or the other, which would be a complete recovery, or head towards maybe a longer or some additional complications like CTED or CTEPH. So again, there's a little bit uncertainty there as far as definitions are concerned, which are overall important, because in research it's important that we are speaking the same language and we're discussing about the same patient. But for today or this conversation, I'd say the patient on anticoagulation, those 3-month mark has passed, and patient is still symptomatic, and you are now in that space evaluating them. And overall, I think this is a good timing to discuss this, because for many decades, I think the entire focus has been on that acute recovery or acute survival phase of PE patients, which is, of course, very, very important. But lately, in the studies, in the research world, in the clinical world, we are very interested now to know about what are the long-term implications of what we do acutely. Does it matter, one therapy versus the other? And how do these patients do, and what can we do to ensure that full recovery?
Dr. Naydenov, thank you so much for very, very clearly defining this quote unquote syndrome of illnesses, and really just clarifying that it's more of a spectrum that we should keep an eye out for. So at her 6-month follow-up, Miss Lism was still breathless when she visited us in clinic. So her physician at that time began to wonder, have we potentially missed something? Dr. Naydenov, how do we screen for post-PE syndrome and its various components? And what are the things that we should be keeping in mind when we see these patients at this time?
So, first and foremost, I'd say a structured follow up is the key because every practice varies, your resources vary. So, it depends who that point person would be, whether you have a great PCP follow up or cardiology, pulm, multidisciplinary clinic, whatever, you have to take that intake as to what is the best way. But I'd highlight the point all PE survivors need a structured follow up. I'd emphasize that point. And that structure can depend on your individual resources. So that intake is important. What can you do to ensure that that happens? How do you want to do it? The data is clear about a little bit of guidance from some of the studies like ELOPE or Focus that 3 month, 6 month, 12 month, plus minus 16 to 24 months. And I'll explain that timeline a little bit. Overall, what you're trying to do is it's kind of a map in a patient's life after PE, and you are establishing these checkpoints. And these checkpoints are important to establish or get some questions answered. First is which pathway is the patient on as far as recovery is concerned? Because, like I said, something hit them, something changed, and that's kind of the storm that PE happened. And then now you are putting them on this map of recovery and having these checkpoints established. I personally would recommend 3, 6, 12, and plus minus 16, 24. And the data behind that is to pick up on those patients who may develop CTEPH. And that's the most important piece because that's a deadliest disease spectrum that you can have, or the deadliest disease on the spectrum that you want to identify. And you don't want that patient to fall through. So why it's important is because perhaps you can make a difference in their life, like completely, by offering them a therapy which is not available in some of the other disease, potentially curative therapy. So that's important to pick up. So you don't want to miss. And CTEPH generally, the data from many decades show that the diagnosis is delayed many months, past 10 months, 12 months when the disease is diagnosed. And then lately, the structured follow-up in some of the data, one registry from UK suggests that if you have a structured follow-up, you can identify perhaps in 4 to 6 months, which is very important in changing a course of somebody's life. So that's why the timeline that you want to pick up, average about a year, 88% of the patients, if they were to develop CTEPH, you'd see it. And then leverage about if they haven't in about 16 months to 2 years, they're probably going to do okay. And then you can at that time release them to their good outpatient primary care follow-up. So that's kind of the structured follow-up and a little bit of guidance on the timeline. And just kind of extrapolating that to my personal practice, I usually have a little bit of a difference that I like a 2 to 3 week to a 30-day check-in, like a bridge check-in with the patient. That is not really to, especially I'll tell you which patient population I recommend that or suggest that. But the goal behind it is to have a checkpoint established on those patients which are maybe high risk and maybe had TPA or they had profound shock in the ICU or maybe they required ECMO support during. So those patients, I feel like 3 months is too much to wait because a lot happens. Sometimes they don't have that understanding as to what happened. They can't wrap their head around what happened during the hospitalization. So that 3 week to a 30-day check-in is basically, hey, are you doing okay? Symptom check quick. Do you have your medication till your follow-up, everything, and the right dose of it? That would be very, very important to discuss. Are they tolerating that bleeding risk assessment? Just a quick check of making sure that they're tolerating the medication, okay? They're aware of their appointment that's coming up in about 3 months, and they may have a question. And also a little bit of a red flag. Are they kind of heading in the direction that you would expect the patient to be? Maybe they are on oxygen. That's significant, the supply and the use, they may have a question. So I like that little quick check on some of the more severely ill patients that we identify. But most of them, like I said, a 3 month for sure, 6, 12, and 16, 24 plus minus that time. I'm talking the months. So that's important, the structured follow-up. And I think the second layer of that is how do we screen these patients? For example, the patient that you mentioned, if she's in the clinic at their 4-month mark, first thing would be the inventory of patient symptom. That would be the key. You want to know how they're doing. And rather than a subjective assessment, I would lean on an objective assessment. So some of the scores could be, MMRC is a good one for their dyspnea evaluation, gives you some objective sense. And the other one is post-VTE functional status scale. That also is a simple one to use. Those two are kind of my go-to The other one, which is very comprehensive, the Pulmonary Embolism QL questionnaire, is very comprehensive and very good. But honestly, I just have a comment on the scoring system. They're good when they are also a little bit practical and easy to do. If the scoring system is going to take about 15 minutes, unless we find some other ways to capture that information, it becomes tedious and you lose it sooner or later. And I think that's where the challenge is in developing a score. So I usually lean on the VTE functional status assessment on that scale and then the MMRC. But like I said, I don't have any fixation on one versus other. If you can regularly do the QL questionnaire to learn about the patient's six spectrum of illness and where they're at and their functional status, that'll be great. But again, I find it challenging if something takes 15 minutes to do. But for the future, I'd say, with the technological development and all the AI integration and stuff, perhaps these are the things where technology can become very helpful. Because I can see a patient in my ideal world, if they have, for example, an appointment coming up and they have maybe a MyChart or some kind of a tool to use before even they come to the clinic and interact with it in a friendlier way to answer those questions. And I have that information on my dashboard on my screen. I'd like that. Because for me, these scoring systems and these questionnaires are like dashboards. If a light is blinking somewhere, I'll pay attention to, oh, why is this? Why is that? So I'd like to have that information presented to me in some form. But right now, obviously, we all do it kind of more or less manually and figure it out. But I'm hoping maybe with technological interventions and all this AI development, we can utilize it there and make this easy for us, also easy to identify patients. Not that I want my labor to be reduced. No, that's not the point. Because I think with electronic, the consistency can be better. Also, the visual of having that information and the ease of patient data gathering would become easier. So I'd say structured follow up, establish the timelines. I've given you the little guide there, and also like some objective screening test available to you. And then based on that, you will decide what test are you going to do. I usually start with a non-invasive, and if you want, I'll elaborate on those testing.
Thank you so much. I'm honestly so glad we're digging into this concept of ongoing VTE care. I know I'm a proceduralist, but I really would like to have continuity with my patients after invasive management. So this comes down to the heart of exactly what I was excited to talk to you about. You actually already answered one of my questions was, how do we tease out some of these symptoms? And if you had a preference on a questionnaire versus another, and it sounds like you are leaning more towards the more simple ones, which is PVFS and MMRC. I was exposed to the PE Quality of Life questionnaire a couple of months ago at the PERT Consortium meeting, and I really liked it. But like you said, it was quite long, and it almost seems better suited for research, honestly. But it seems like you didn't have one versus the other, and you did go to one that was a little less cumbersome. I had a thought, actually. I wondered if, maybe your intake nurse knows that this is a post-PE follow-up patient, could perhaps do that questionnaire for you, or maybe it's included in the visit information that the patient fills out before they come in, and then, it's right there auto-populated in the chart for you as you come in. So that's one thought to do. Another question I had for you, and perhaps you could, take this for me, is what about recurrence risk calculators? Do you use any of those for patients, and when to choose the duration of anticoagulation for these patients?
Great questions, really. This is just so important. I'm excited to talk about this, because there's uncertainty, there's lack of clarity. We have some guidance, but there's a lot of personal choice and practicality of things. So I think I like your idea that somehow this data is gathered by a nurse or somebody who's working with us ahead of time. I honestly like automation a lot because I feel like in this day and age, we need to rely on technology a little bit more for these kind of objective data information rather than any human being doing it. So I extrapolate your idea, but I'd prefer if I have to devise something in my ideal world, I'll have a computer check in or something. Unless the patient doesn't have that literacy or tool, then I'll find another way to assist with that. But I would like it, like you said, have it presented ahead of time without me or even a nurse having that intake done. So that's important. And you mentioned the recurrent risk. So I'll get into some of the scores there. So the first thing is when we are seeing patients, PE patients, and the follow ups. So this is kind of what you're alluding to, I'm assuming, and guessing that first is you're tracking their recovery, right? You're tracking their recovery. You're making sure they're taking the anticoagulation, and you're very concerned you want them to recover fully. That's our goal. We want their functional status to be restored to the best that it can. We cared that they survived their acute illness. We did everything. And a lot of good work is being done by this multidisciplinary approach. by making sure that we deploy the best resources, we deploy the best tools to make sure they survive their acute illness. But now that has happened, they've come to you as outpatients. So I think as we discuss their recovery path on that map of recovery, we have their checkpoints. The other concern is that anticoagulation continuation versus discontinuation. So, of course, it depends on what their risk factors are, what the situation was when they had the piece. All those factors will, of course, need to be accounted for before we decide on the continuation or discontinuation. So I do use the scoring system. I'll go into the details of that, but I'll tell you from practical and knowledge that first conversation is that if you're even considering that or not, right? Because if the patient, like your patient that you mentioned, that question is not there at that time. If she's 4 months and perhaps the travel played a role in her PE, but she's symptomatic, so that question will not be for me, at least not at that time. If she has recovered, for example, in a year or 6 months or so, then I will entertain that question for her. That, she's like, I think she was a little bit older, like 50 some year old. So, younger patient, trauma patient, different situation, provoked or unprovoked, any identifiable trigger, major, minor, or lack of identifiable trigger, active cancer, no active cancer. So, all these factors will play a role. So I like the simpler ones again. I think that's just me. I like the DASH score, or for women, younger, HER2 2 is also simple, very simple to do. I would say mostly those two. I know about some of the others that we can perhaps consider. It also depends if the patient is on anticoagulation or not. I had a patient I remember, they had just stopped their anticoagulation. I think 2 or 3 months had passed. So, the Vienna score can be considered, or even the DASH, because there's also a disruption of anticoagulation there. So you're like, shall I restart, not restart? So D-dimer plays a role over there. So again, it does come to perspective. I cannot say that you have to decide that based on the situation and the patient preference. Many of my patients don't even want to get off the anticoagulation because thankfully we have this transformational change in anticoagulation regimen for PE since we have the DOACs. So that if that question is on the table, then you have to use the score. Again, I use the score based on the situation. I don't have a preference, but I would go for a simpler one.
Perfect. Okay, so Miss Lism underwent chest X-ray, ECG, and CPET with tests coming back normal, but her symptoms frustratingly persisted. So Dr. Naydenov, at this point, should we be considering other testing or reassuring the patient? What's going to be your approach?
Okay, so I would assume that the first time that she came to see me, I had done the echocardiogram. Those are the basic first tests I do, like a VQ scan. I usually do a full PFT and a 6-minute walk as well. So I think if those were done at 3 months, I would assume now you said she's about 6 months out, still symptomatic, and CPAT is normal. Is that right?
Correct.
Okay. So then again, you have to discuss the symptoms again. It's not a unreasonable idea to now think of more invasive testing. She has not returned back to her baseline. So some of the testing, you said if you've done the regular CPET, that may have highlighted something, but if it did not, perhaps you can repeat a VQ scan at this time, perhaps even an echocardiogram if you feel like symptoms have changed to some degree. Other things you can do is now maybe right heart catheterization. We have done both, you can do it at rest if you're really concerned about hemodynamics, and also exercise, because many of these patients, you don't see things at resting stage. So having an exercise, right heart cath, or even invasive CPET could be a consideration.
Thank you so much for that, Dr. Naydenov. So then Miss Lism returns to our clinic, and at this point she asks whether there was anything else that she could have done to prevent her recent symptoms. So what can we do to prevent post-PE syndrome in future such patients? And what is the role for long-term anticoagulation in patients like her, such as things like early abbreviation that may be guided by markers such as D-dimer?
Okay, great. So I think first off, if you think about her recovery, I think she still could be on the path of her recovery, and maybe she just needs a little bit more time. So at this point, I still think that she will be somebody that you are continuing anticoagulation on. For prevention, I think the first thing that I would advise all patients is to take the anticoagulation and be compliant with it, which looks like she did. Pulmonary rehab has some role. I just don't know if we have a tool that we clearly know will prevent this. I wish we did. We just have to advise the best possible kind of a combination of regimen that you can think about, which will include their general precautions. If they're smoking, don't smoke. If they are, body weight can be a consideration, and pulm rehab plays a role in patients' recovery faster than if they don't do that. Resources can be challenging there, as we all know. And of course, the anticoagulation. Other than that, I don't know of any particular tool. Also, it's very, very important area of our interest. What we do acutely, is there something which we're going to hopefully learn in the upcoming trials? Does it matter what we do in the acute situation to prevent these long-term sequelae? Unfortunately, we have some signal towards that in some of the trials. Like even if you look at the PYTHO trial from 2014, 2015, they looked at those patients long term, though the study was not meant to look for those outcomes. They didn't see patients who got this is intermediate risk PE, who got the thrombolytics. They didn't see the reduced rate of chronic thromboembolic pulmonary hypertension in those patients. So we don't know. We have a signal that we're doing some benefit in short term to prevent these long term sequelae, but we yet have to learn. So for patient, I'd say body weight, check, rehab, anticoagulation is the way to go. So for this particular patient, did anything that she couldn't have. If rehab was not in check, that maybe I would consider that and give her a little more time. So I think I like using the D dimer. I just don't know the practicality of deciding based on it. I think patient symptoms would be preferable to guide you. That's what decides in practical terms. Whether you're dealing with a patient, for example, you have picked up on some residual defects in your VQ scan or SPECT scan or PA-gram, or a patient who is kind of on the milder or the borderline of normal hemodynamics on right heart cath, or again, the PA-gram if you have the pressures. So it depends a little bit on those things and the symptoms compared to any biomarker that I can trend. Unless it's a discussion more on stopping the anticoagulation or not, which again, we have discussed briefly, some data that you pause, interrupt, and then see the D dimer. If it's negative, yes, you can continue patient to not be on anticoagulation. And if it's high, you resume the anticoagulation. I usually don't decide D dimer on a patient that you have mentioned, other than allowing her time and symptom recovery if that happens or not. And perhaps consider additional testing, like I mentioned a few of them. I would maybe add a PA-gram just to make sure that the vasculature is assessed and we don't have anything that we haven't picked up on a patient like her.
Perfect. So I'm going to just, as a brief recap, just from myself then, we're thinking of her as a whole picture here. And, she comes in, she's still symptomatic. I'm not even thinking about dropping my anticoagulation yet. Now, on the flip side, had she come in at her 6-month appointment and she felt completely back to her baseline and her risk scores were very low, this may be someone that we either just go ahead and stop the therapy on, or at the very least talk to her about that trial off, followed by a subsequent D-dimer and let that decide whether or not to restart, like you were saying. And then as far as her being symptomatic, we're looking at those non-invasive exams like that 6-minute walk, an echo. You said you do full PFTs and a CPET. If all those things are normal, she's symptomatic, you may think of the next invasive thing, whether that be a right heart cath plus or minus exercise or plus or minus an invasive CPET, and then maybe even repeating some of your non-invasive tests if things aren't lining up. So that was fantastic. Thank you for going through that. Just to clear up our patient story, at her 1-year follow-up, Miss Lism had returned to her baseline level of exercise and was very grateful to be able to resume her spin classes without limitations. And Dr. Naydenov, you actually hit on some of the things I'm very interested in. You were talking about if maybe some of our trials or these so many different devices we have now, transcatheter, whether that be CDL or large bore catheter thrombectomy or anticoagulation alone, varying doses of lytic, may help us with those long-term sequelae, whether that be CTED or CTEPH. Do you have any idea in your mind where you may go one way or the other? Like perhaps CDL may be more effective for those distal collide and have less CTEPH later on, or do you think there's anything signaling one way or the other?
Oh, that's a different area we're entering now, but an exciting one. So I would just briefly go back to the patient that you've mentioned. It's great to know. We are going to celebrate. It's a year in and she's fine and back to her spin classes. Things I would add to make sure it's like an opportunity when they came for these check-in appointments or your follow-ups, that they're age-appropriate cancer screening before I, for example, do a dash score on her and then decide on discontinuing. So some things just to close the loop on her is age-related cancer screening. I may still offer reduced dose anticoagulation. Sometimes we know from some of our anticoagulation studies that you don't have to turn it. It's like a light. You can dim it. You don't have to turn it off all the way. So maybe the reduced dose, I would offer her that. Some patients don't want to get off. The other D-dimer you already discussed, maybe travel related. If her initial event was travel related, you can consider there's some data to support offering her travel related anticoagulation. Maybe she likes to travel for work or something like that, especially if it's a long haul flight. So that would be my conclusion on the patient that we discussed to complete her care spectrum. About the endovascular space and all the devices that are coming out, there was started with the Ultima trial, really, as you all know, 2014 anticoagulation, which was unfractionated heparin versus the, and I'm kind of doing this recap just for myself to bring us to where we are. Really, I think overall PE care has just transformed. It's not the same PE that we had 10, 15 years ago. And I think the big pivot point is when the Ultima was published, because we didn't know what to do with these intermediate risk PE. Is anticoagulation enough or not? Shall we do systemic thrombolysis? It seemed too much to do, but it was finally with the PYTHO study and the Ultima, we had some signal that started making all the clinical decision making that changed. So Ultima showed that if you do catheter directed thrombolysis for patients with intermediate risk PE, you can have reversal of that RV-LV ratio faster than anticoagulation alone. Anticoagulation can do a great job. It just takes longer. Like I think 30 days, everything kind of mashed out and they were equal. But we know that if the patients deteriorate, as we learned from the PYTHO trial, 1,000-patient study, tenecteplase versus anticoagulation, again for intermediate risk PE, we learned that many of these patients deteriorated. And I'm just kind of focused a little bit with your question, taking opportunity to talk about intermediate risk, because on the other two extremes, data is relatively clearer, especially with the low risk. High risk, we are still learning because even the high risk has so much spectrum, right? There's catastrophic PE where you need to do something like right now on the bedside. But then there's somebody on a little bit norepinephrine where you may have a little bit time to maybe take them to the cath lab or IR suite to do something. So that's another spectrum. But the majority is this intermediate risk. So Ultima changed this clinical signal towards reversal of RV-LV ratio that we extrapolated was kind of benefit that we are doing for these patients. Has that translated into clinical outcomes? Because if I go to the patient's bedside and say, okay, you go through this procedure and your RV-LV ratio will be better in 24 hours more than if I don't give you this therapy and give you anticoagulation only. So again, what does that mean for the patient? You know, they look at you as to like, what are you talking about? But then you have to explain, you think it's going to do some clinical benefit. So we are going to learn that. The two trials that I'm looking forward to are the HiPyTHO, along with a few others, are the HiPyTHO, again, catheter thrombolysis, very structured control arm of anticoagulation. And it also has a lot of other meaningful patient inclusion criteria, which I'll take the opportunity to discuss briefly. But overall, the space has evolved, as you all know, in the last 10, 11 years and exponentially evolved. And it has changed. The systems around PE care have changed. Like I said before, it's not the same PE like before. So space is evolving. We have to learn that these clinical questions need to be answered for a patient. Are we doing some benefit, which translates into clinical benefits, not just RV-LV ratio, which is good, but how does that translate into short-term and long-term clinical outcomes for the patient? I'm hoping PE track would answer that. And this goes back to your entire podcast today with the discussion on this post-PE space or post-PE disease or sequelae, which is fascinating and very, very important because we care. We care about the survival, but then we care about how it, manifests long-term. So PE track is what I would look at and follow. I think the recruitment is more than halfway done there. And the HiPyTHO is another one because we yet haven't answered this question, despite of some recent trial that got published, is anticoagulation alone versus anticoagulation plus, which is like endovascular intervention. So there's no comparative data to say that we are doing benefit. So HiPyTHO will help answer. And now the third question comes to, if I say catheter-directed therapy, what does that mean? Can we translate catheter-directed thrombolysis to mechanical thrombectomy? And mechanical thrombectomy is done in so many ways, you all know, and they're not all the same technique. There's so much variability in that. So I'd say we don't know. We yet have to get these questions answered. But I'm hoping in the next year or so, these two trials, along with a few others, will help answer these questions to what clinically it means for the patients when we are considering these therapeutic options. But it's exciting that we have more options or more tools available to us with expertise available to us to offer to our patients with perhaps, I'm hoping, for long-term benefit and prevention of these sequelae that we have talked about that can be very debilitating to their recovery.
Dr. Naydenov, thank you so much for that wonderful overview. It's been so exciting to see the way that PE management has changed even in my short training period already. So we'll really look forward to some of these additional trials coming out, and particularly paying attention to trials such as PE Tract and HiPytho. So at this point, Dr. Naydenov, we wanted to ask for our listeners here, what are some of your main takeaways for cardio nerds that are tuning into this episode?
Okay, great. So main takeaway would be, first, pulmonary embolism is not one and done with anticoagulation. That would be my first point. All PE survivors need a structured follow-up. Otherwise, for you guys, I'd say the heart suffers. So I think those two would be my points. Not a one and done approach with anticoagulation, and all patients need a structured follow-up.
All right. Thank you so much. And my last question to you today in true CardioNerds form, can you tell us what makes your heart flutter for PE management?
You have spoken like a cardiologist. Okay. So, all right. I think.
You could say lungs, like lungs inflate, something like that if you want to.
No, I like that. I enjoy it. This is good. No, you guys got to be you. I like it. I loved it, actually, the heart flutter about PE. No, good. Okay. So, what makes my heart flutter about PE? First and foremost, I'd say it brings us together. It brings us together, hematologists, pulmonologists, cardiologists, vascular IR, surgeons, and you have been involved in the PERT Consortium. So I really find that as a very, very strong, centered, PE-centered approach that we get together, just like this podcast today. But if I'm PE specific, I like the uncertainty. I like the challenge, because uncertainty exists, challenge exists, that also gives you an opportunity to create a path that is not there yet and being a part of it. Long answer, but the creativity around what we are all doing right now and learning together, that makes my heart flutter. So that would be my two things.
Well, that is very heartwarming, I will say. Huge thanks, Dr. Soophia Naydenov, for sharing her expertise, and to Saahil and Billy Joe for leading such a thoughtful and impactful conversation. We've covered a lot today on post-PE syndrome and long-term management, and we're just getting started. So stay tuned for more episodes as we continue exploring the evolving world of pulmonary embolism care right here on CardioNerds. Check it out.
Thank you so much for tuning into this CardioNerds episode. The audio editing for this episode was performed by me, Grace Qiu. I'm an intern in the CardioNerds Academy, House Jones, and medical student at Thomas Jefferson University. Check out the episode page for show notes and references. If you found this episode or show informative, please consider subscribing to CardioNerds on your favorite podcast platform and leaving us a review. It really helps us spread the word and further our goal to democratize cardiovascular education. Finally, this podcast is not meant to be used for medical advice. The views expressed on our show and site do not reflect the opinions or policies of our employers. All CardioNerds content is planned, produced, and reviewed solely by CardioNerds. Stay tuned for more engaging conversations and explorations in our new and exciting upcoming episode. And now, my friends, it's time to make like an S2 and split.